Good evening, ladies and gentlemen. On behalf of the Ceylon College of Physicians, I am Himanta Tukorla. Welcome to the very first of a brand new series of webinars titled Collegia Unitum Scientia, Colleges United in Science. Today, we are honored to feature Dr. Satish Gunasinghe, President of the College of Surgeons of Sri Lanka. Dr. Satish will deliver a speech titled Urology Science Scalpel, Medical Management of Urological Disorders. I would also like to remind our dear viewers that questions will be entertained at the end of the speech. You could type your questions in the questions box at the bottom of the screen. To tell you all about this new venture and how it came to be, and to further introduce our guest speaker, I cordially invite the President of Ceylon College of Physicians, Dr. Arosha Disanayak. Over to you, sir.
Right. Thank you, Himanta. A very warm welcome to all of the members and the fellows and past presidents of the Ceylon College of Physicians for this venture. This is a new series, as Himanta introduced. Traditionally, CCP has been collaborating very closely with the sister colleges, the other physician colleges such as cardiology, respiratory neurology, etc. But collaborating with non-physician colleges has not happened that frequently. And collaborating with the College of Surgeons has been even less, probably due to historical divides that we've had. But then the theme that we are running in this year is crossing divides and bridging gaps. So as the first venture, we thought we will reach out to the College of Surgeons, and we are indeed proud that we have the president, the newly elected president of the College of Surgeons of Sri Lanka, Dr. Satish Gunasinghe, with us today. This, I believe, is Satish's first official engagement as president of the College of Surgeons, and it is indeed a privilege to have you speaking to us. Now, the theme, Collegia Unitum Scientia, Colleges United in Science, that came about through Himanta. Himanta is the Latin scholar on the council. My Latin is restricted to what I garnered from reading endless hours of Asterix comic strip books. So it is Himanta's brainchild, and even the poster that we designed, that I'm sure all of you know, that's Michelangelo's creation of Adam from the ceiling of the Genesis. So that image shows the reaching out to each other, collaborating. There is, of course, one of those hands belongs to the God and one to Adam. We are still to figure out who is creating whom, whether it's the physician who is creating the surgeons or the surgeons who is creating the physician. But that image is there, and there has been a suggestion that the College of Surgeons and Physicians, there should be a presidential debate at some stage during the year, and maybe that could be the subject of a presidential debate in time to come, who creates what. But I'm sure the more pertinent question at that time will be who created Eve rather than Adam or God. So that's in terms of our team. And then with regard to the speaker for today, we have Dr. Satish Gunasinghe. He is a consultant urologist. From a clinical perspective, Satish is one of the most visible urologists in Sri Lanka. He is clinical. He has excelled in his clinical science chosen. Satish is a top-class researcher. He has published both about urology and also about medical law. And the fact that he has an LLB as well as an attorney at law has helped his publications. He has held excellent academic positions and excelled in those as well. He has been the president of the Kurunegala Clinical Society, subsequently Association of Urologists of Urological Surgeons of Sri Lanka. He was Gold Medical Association president in 2016, and I was on the council with him. And then, of course, he's now the president of the College of Surgeons of Sri Lanka. To me, even beyond all of these great credentials that Satish possesses, to me, Satish is one of the most humane doctors I have ever had the privilege of meeting. Even in the middle of the COVID crisis, his newly refurbished ward, he sacrificed for COVID patients for more than 1 year. He's that kind of person. He has a MPhil in Buddhist studies, and then he tried to explain one day what his MPhil thesis was, but it was a little beyond me. But he has attainments there as well. Satish is a role model for other doctors, and it is indeed a great privilege for me to have a man of his stature speaking to us in this first in the lecture series of Colleges United in Science. Satish, my very dear friend, it's over to you.
Thank you very much, Arush, for your kind words of introduction. This is an excellent venture where we, the surgeons, are cooperating with the physicians. We all have a common aim, is to alleviate the suffering of patients. I think we are united in that sense, and there's no division as such. We take different avenues, and the boundary between medicine and surgery is getting blurred as well, as I will elaborate in a while. I would say, chirurgy sine scalpello. Well, that means here comes the surgeons without the scalpel. So as we are coming to the College of Physicians, we thought of coming without the scalpel. So I want to discuss about, 1 minute, I'll share a screen. So basically, I'm going to talk about urology sans scalpel, medical management of urological disorders. Basically, who are urologists? What do they do? We are a group of surgeons. Then we would ask ourselves, who are surgeons? Surgeons are clinicians who use mechanical methods to cure disease. But you'll realize now there's a blurring of boundaries within medicine and surgery. Basically, we use mechanical methods. As we see, cardiologists insert stents, they close atrial septal defects. We have interventional radiology. So surgery, the boundary between surgery and medicine, traditional medicine, are getting blurred now. We treat men, women, and children, and we treat patients involving diseases involving the kidney, bladder, prostate, and male reproductive organs. Nephrologists look after the way urine is produced, and we make sure that the produced urine is passed well. So the diseases that we handle include cancer, stones, infection, incontinence, sexual dysfunction, and pelvic floor problems. So basically, this is what our specialty entails. The urologist is basically a plumber. We deal with the urinary system, series of tubes in series and in parallel, and we try to make sure that the produced urine passes well. It could be problems in the kidney, ureter, bladder, urethra, or associated organs. So basically, our role is being plumbers who make sure that people pass urine well. The production of urine, of course, as we know, it's in the forte of physicians, the nephrologists. We also invariably, we are part of the water cycle, and we process water, we pass water, we have to pass water well. And once again, this water enters the water cycle in the environment. So as I told, blurring boundaries are there. There are defined boundaries on medicine and surgery. And we see, as I told, medical specialties going beyond medicine, cardiology with the armamentarium of their interventions. And surgical specialties are also going beyond the traditional confines of surgery because they are concentrating on medical interventions. So the role of the surgeon is diminishing in some of the disease. This is a dynamic process that we see, and with time to come, with the characterization of diseases, we'll be able to have more advances. So we are probably infringing on our territories, but these are with good intentions. In a similar vein, we had an editorial published last year in the Gall Medical Journal, where we considered the role of modern surgery, the dynamic frontiers and blurring boundaries. So the traditional role of the physician, traditional role of the surgeon, they are changing actually. Barbers, physicians, like that, things are in a state of flux. Medical interventions in urology, how were they brought about? They were enabled by better functional characterization of the urinary tract. At molecular lab levels, studies were done on receptors, how cells behave. So a scientific foundation was given. And this helped in sort of modulating and curing disease. And this has enabled focused treatment of certain conditions like incontinence, bladder outflow obstruction. And once again, medical interventions in urology has reduced the number of surgical interventions, especially in bladder outflow obstruction secondary to prostatic enlargement. So we are in an evolving state of medical urology world over, as all the frontiers of medicine. Urology is evolving, medicine is evolving, surgery is evolving, all the disciplines are evolving. It's not the medicine or the urology or surgery that we knew as medical students that we see now. And I'm sure it's bound to change. So much so, the British Association of Urological Surgeons have started to publish a journal, the British Journal of Medical and Surgical Urology. So this gives the increasing importance of non-surgical management of urological conditions. So it's not the time of the surgeons who just cut patients. It is the time of the surgeons who are scientifically inclined and who analyze disease well. And if there's an option is available for surgery, then he would endeavor to do surgery. So it's an approach which is best for the patient. So in tonight's brief talk, I would like to focus on few areas which all we are familiar with. Firstly, bladder outflow obstruction or benign hepatic hyperplasia. It's a nuanced term. There are exactitudes here, but there are definitional differences. I would elaborate on that. Secondly, I would like to briefly focus on overactive bladder syndromes and also medical expulsive therapy, which is being used by people without a foundation on that, of urinary tract stones. And also there is erectile dysfunction and ejaculatory disorders. I think that will be another topic by itself, and I'll be boring it to the core if I go talk about that topic. It's a very important topic from sexual medicine, cardiology, and vascular surgery, urology. But I think that's beyond the scope of tonight's talk. But that too is an area where medical interventions are helping urological disease. To start with, the urinary tract has two mutually dependent components. It's the obvious, but I would like to just restate. There is an upper urinary tract, which is composed of a kidney of the ureter. And in the upper urinary tract, urine is being continuously produced. And then we have a lower urinary tract, which is composed of the bladder and the urethra, where the bladder, the urine is being stored. I think almost all of us are storing urine at this very moment. And when a critical volume is reached, of course, textbooks of physiology used to say 400 ml, but there's a large interpersonal variation. We get the desired and pass urine. So that's the lower tract. So upper tract, lower tract. So it's a highly sophisticated system of conduits. Continuous so as I told, there's continuous involuntary production of urine in the kidneys and intermittent volitional micturition in appropriate conditions from the lower anal tract. But of course, this intermittent volitional micturition also has themes and variations, as we know. A newborn would not have volitional micturition. If a person has dementia or he has some neurologic disorder or some form of disorder where he cannot control, there'll be no volition. So that's disordered function, and as also physiological difference. So it's theme and variations we see. And we have two phases of lower urinary tract function. One is what we are doing, all of us are doing now, we are storing urine, that is the storage phase. And when we pass urine, we are in the voiding phase. So voiding and storage are interrelated, yet they are distinct phases of lower urinary tract function. Of course, there are a lot of physiological bases behind this, which have been understood really well with a lot of neurological inputs, but I would like to sort of elaborate on those. So basically, we have two phases, storage and voiding. So if we try to define it more precisely, lower urinary tract has storage and voiding, but if we make it more well defined, it's adequate storage of urine, collection and low pressure storage of urine without leakage. All these words are important. If there's leakage of urine, the whole purpose of our body, to store urine, is lost. So it is adequate storage of urine, its collection and low pressure storage of urine without leakage. Secondly, voiding entails efficient expulsion of urine. Efficient expulsion of urine at an appropriate time and at an appropriate place. This is Murcutt's adults. So there are a lot of things here involved. There are the bladder function, the urethral function, the spinal cord, the brain, the cognitive functions, a lot of things getting involved. So much so, there was a urologist called Bates who told that the bladder is an unreliable witness. So if you look at the two extremes of lower urinary tract dysfunction, one is failure to stow, and other thing end would be failure to empty. If it is failure to stow, we call it incontinence. Storage failure, the extreme end, is incontinence, and voiding failure is called urinary retention. I mean, it's very obvious to all of us, but in between storage failure and voiding failure, we have the lower urinary tract symptoms. This is a very basic conceptual element that we urologists and all clinicians should have to appreciate, but there are a lot of overlaps here. First, I like to focus on this gentleman is having problems in passing urine. Medication to have a better urinary stream. How can we give medicines, drugs to have a better stream of urine? So here I would focus on benign prostatic hyperplasia. Traditionally, there is confused terminology. I think if you remember, sometimes our seniors used to call this prostatism, which was a very vague term. In the early 1990s, a urologist from Bristol called Professor Paul Abrams coined the term LUTS, lower urinary tract symptoms. So about 20 years ago, with poor and variable patient selection criteria, surgery was the only option. And some never fared really well in surgery because they were inadequately assessed. So definitionally, some people tend to think blood outflow obstruction, lower urinary tract symptoms, benign prostatic hyperplasia, benign prostatic enlargement, all of them are the same or they are synonymous, but they are very different. Of course, there are overlaps between these terms, but I'm not going to sort of go on a definitional debate here. But lower urinary tract symptoms are basically LUTS, or we call it LUTS, storage symptoms like increased frequency of micturition, nocturia, nocturnal enuresis, urinary urgency, different types of incontinence like stress, urge, urgency, and overflow. Those symptoms would be classified under storage symptoms. Voiding symptoms are the symptoms that we have when we void. They are really, as you go, you have to wait for some time. That is hesitancy. Then when one passes urine, it will be slow. That will cause slow stream or poor stream. And then we have intermittency. And finally, it would culminate in a retention. Of course, there are different types of retention, pain, acute and chronic. Acute can be painful, painless. Chronic can be high pressure, low pressure, but I'm not going to elaborate on those. There are different types of retention states that we encounter. So voiding symptoms are one group. Then there's a third group which has been defined by the International Continence Society. Those we don't talk about much, but they also they're the third set of post-urinary tract symptoms. They are called post-micturition symptoms, especially post-micturition dribbling some people have, and some have strangler. They feel that they have voided incompletely. Those are grouped under post-micturition symptoms. So a whole myriad of symptoms causing lower urinary tract symptoms. Just to run fast, I mean, if you take the symptom of increased frequency, if you are going to analyze that problem, there are lots of causes we can think of. If you are taking history, any cause of polyuria. And now I'm not going to talk, physicians would teach me on what the causes of polyuria. So any cause of polyuria would cause increased frequency. Secondly, if there is bladder irritation by infection, cystitis or carcinoma in situ, that would be increased frequency. If there is reduced capacity of the bladder by either a large space occupying lesion, like a large tumor or large stone, there'll be increased frequency. Or on the other hand, if there is a contracted bladder after radiation or tuberculosis, chronically contracted bladders, they will have increased frequency. Or if they have overactive bladders, either it could be idiopathic, it was called idiopathic Lithotripsy instability. Now we call it overactive idiopathic overactive bladder overactivity. Or there could be neuropathic situations. So likewise, if you look at lower urinary tract symptoms, and if I took one symptom, there could be lots of pathologies which are in the background. So they need a very careful analysis in order to arrive at a diagnosis. So LUTs are a group of symptoms which could signal almost any disease in the lower urinary tract or the nervous system or anywhere. Then the second term is benign prostatic hyperplasia. Now, hyperplasia, as we know, is a pathologic diagnosis where the increase in the number of cells. So PPH is basically a pathological diagnosis. So I think it's unfair for us to say this patient has PPH unless we have a walking microscope with us. So the better term is the last one, benign prostatic enlargement. It is clinically we feel that the patient has benign enlargement of the prostate. Bladder outlet obstruction is another entity, which is it is an obstructive state, but it could be urethral stricture, prostate enlargement coming. So I hope my physician colleagues would realize the terms LUTs, BPH, bladder outlet obstruction, and BP are quite different. This is a good Venn diagram. I think if you remember our mathematics we learn in school. In Sinhalese, we used to call them Tulaka. These are what we call it's a Venn diagram, VENN. So Venn diagram shows whole group of 40-year-old men. We see the entire group is 40-year-olds. And in that group, we have histologic BPH in this group, the large group over here. And within that, the benign prostatic enlargement. And there's blood outflow obstruction and LUTs. So these are different groups of symptoms, conditions, though they have a similar appearance or a manifestation, they are different entities conceptually and clinically and in reality. This was initially proposed by Tag Hall, but it's been continuously, these Venn diagrams are being revised by urologists every year. So this gives the real, the nuanced situation of the urinary tract symptoms. When you look at benign prostatic hyperplasia or benign prostatic enlargement, there are different drug classes being used. And first group are the alpha adrenoceptor blockers. They are alpha blockers that we use to relax the smooth muscles in the prostate and the bladder. The second group, we have 5-alpha reductase inhibitors. They inhibit the activation of testosterone to dihydrotestosterone, the active form of testosterone. Then we use a combination of alpha blockers and 5-alpha reductase inhibitors. I will elaborate on that briefly. And what we use for erectile dysfunction for type 5 diphosphodiesterase inhibitors, PDEIS, like Scalpel, vardenafil, can be used also in BPH. This was licensed by the FDA some time back. Patients with erectile dysfunction and BPH can take these drugs as a once daily dose. I will elaborate. So there are phytotherapy. Southern Europe, they use Senoria repens and other forms of, but I'm not going to elaborate on that. That's another entity. But there are clinical trials, randomized clinical trials talking about phytotherapy, mainly seen in southern parts of Europe. The one group is, first group is what we call alpha-1 adrenoceptor blockers. It's adrenal blockage. So they cause actually smooth muscles in the bladder, neck, and the prostate. All these areas are relaxed by these drugs, and it blocks the motor sympathetic adrenergic nerve supply to the prostate, and urethral pressure is reduced, and you will have a mechanically improved urine flow. And they really address actually the dynamic. It's a dynamic state of obstruction is relieved by alpha-1 receptor blockers. So these are commonly used now. Almost it's like paracetamol now. So there are non-selective alpha-1 blockers like terazosin, doxazosin, alfazosin. They were used earlier. Now I think what we see are commonly used are tamsulosin and silodosin. Tamsulosin is generally used in 0.4 milligrams once daily. Silodosin is available in 4 milligrams and 8 milligrams, also in once daily doses. As a first dose effect, they can have vasodilatory effect. Some can have syncope. They have fainting, but like attacks. So first dose, we have to be careful. And most of them complain that they don't have any ejaculation. The reason being, the seminal fluid tries to take the least resistant pathway retrogradely, and these patients on these two drugs tend to have retrograde ejaculation, and they don't have true ejaculation. So some of actually patients are concerned about this. So we have to counsel these patients on these adverse effects. But they are rapid acting. They are very rapid acting. So they address the dynamic factors of prostatic obstruction by relaxing the smooth muscles. But we have to be mindful of the vasodilatory effects and the ejaculatory dysfunction. 5-alpha reductase inhibitors, actually, they are more slow acting. They inhibit the enzyme 5-alpha reductase, which activates testosterone to its active form, dihydrotestosterone. So with that, the volume, there's a diminution in the prostatic size and there will be better stream, but it takes months to act. So it works at another level. So there are two important classes. Finasteride is commonly used at 5 milligrams once daily. And the other drug is dutasteride, which is given at 0.5 milligrams. And dutasteride is more potent because they act on both types of the enzyme. But they attack the static phase of obstruction. So dynamic obstruction is attacked by alpha-1 receptor blockers, and 5-alpha reductase inhibitors inhibit the static component. So actually, these drugs are better for more larger prostates to be treated on, especially prostates more than 30 ml. I mean, 30 ml comes not through digital, but we can objectively assess through ultrasound the real prostatic volume. As all of us would anticipate, sexual adverse effects and gynecomastia can be a problem, mainly during the first year of therapy. Some people actually come with sometimes genital gynecomastia problems. So we have to be mindful of these problems, and we have to counsel patients on this. But of course, compared with, as we can understand by thinking about the actions of the drugs, alpha blockers tend to relax the smooth muscle, but of course, it would just relax for the time being. But 5-alpha reductase inhibitors act on by inhibiting testosterone activation, it tends to reduce the prostatic volume, and they have action on disease progression. So dutasteride, which acts on two types of 5-ARIs, has shown sustained improvement in symptom score and urine flow rates with no increase in prostate volume for up to 4 years. Now that is a very important finding. But if you give alpha blockers, on the other hand, there will be relaxation of smooth muscle, the prostate will go on to enlarge. And when they end up in prostatic, they have very large prostates. But 5-alpha reductase inhibitors, there'll be diminution in the progression of the disease as well. So that's also very important. So it's fine tuning, but I think they are very important. There's another important factor. PSA is almost a panacea for clinicians. Unfortunately, it is done like for everyone with low urinary tract symptoms. Sometimes people immediately after catheterization have PSAs and they're labeled as prostate cancer. We should never do PSAs after instrumentation or catheterization. You have to wait for 3 weeks and do it, because PSA is prostate specific and it is not cancer specific. It can go up in cancer, BPH, and also in infection. And also we have to be mindful. Another important point, 20% of patients with prostate cancer can have normal PSA. But what is relevant in our situation here is that when one takes 5-alpha reductase inhibitors, either finasteride or dutasteride, the PSA levels are halved within 6 months. So sometimes we'll be happy, this guy had a PSA of 12 and now after 6 months he has 6 or he has 10. No, you should not be happy because you have to sort of multiply. This roughly it's a rule of thumb. If you multiply it by 2, you get the true value. So, it is a problematic situation if you are going to assess PSA. The medication also comes to the equation when we analyze the PSA levels. So 2 PSA actually in that patient be double what is on the acid level. And one could argue by reducing the cancer prostate size, cancer prevention can be done, but these studies have shown that they can cure us to a lot of problematic cancers. So we should never use without any problem these drugs. Then there was this case study which came about almost 20 years ago in the New England Journal of Medicine, the top study. It showed if one combines alpha blocker together with a 5-alpha reductase inhibitor, the outcomes are better, flow rates are better, complication rate RRs are much less. So this McConnell's paper, medical treatment of prostatic symptom study, or the top study, is a key paper in urology today, historically as well. Because this study published in the NEJM showed that combination therapy with 5-alpha reductase inhibitors and alpha blockers give a better outcome. So much so, some of the companies have come with the combination. They are not licensed, but they come with combination preparations. Now, this Kaplan-Meier curves, where they have an actuarial analysis of the different drugs, gives these findings. So this is actually from McConnell's paper, which was published. If we look carefully, we see that placebo, of course, with time, of course, they have done a log rank. They have done log rank tests as well to compare the statistics. So placebo shows, if you look at the cumulative incidence of or progression, placebo has highest. Finasteride, doxycycline, they are parallel, but I can't comment what is it. And if you look at the combination, we see they fare extremely well. So McConnell and others have shown that combination therapy gives better outcomes. I think this is excellent. There are different attributes and variables taken in this analysis. And these Kaplan-Meier curves show that over a period of 5 years, that cumulative outcomes are much better in combination therapy. Then these drugs, the type 5 phosphodiesterase inhibitors, or what we use in erectile dysfunction generally, cardiologic applications as well. Tadalafil, of course, we have sildenafil, tadalafil, vardenafil. Tadalafil, 5 milligrams once daily, improved voiding symptoms and erectile dysfunction. So, FDA approved this in about almost 10 years ago, that these drugs can be used in the treatment of bladder outflow obstruction as well. It's not widely used in Sri Lanka, but in a person without who's not taking nitrates, without cardiac disease, with bladder outflow obstruction and erectile dysfunction, one can start tadalafil 5 milligrams once daily to address both the problems. Now, this graph shows that placebo, it has a trade name. Placebo shows more than the placebo. The change from this IPSS means here we say change in the from database baseline. IPSS is a international prostatic symptom score that we use to assess the magnitude of you take in different areas. So here it shows that the IPSS scores are less, where symptoms are much less bothersome with use of tadalafil. So tadalafil has they have a better outcome when it comes to lower urinary tract symptoms. So in general, medical therapy has made a paradigm shift in the treatment of BPH. with subjective symptomatic relief, objective urine flow improvements, and inhibition of disease progression. When it comes to inhibition of disease progression, file for reductase inhibitors are key. And unfortunately or fortunately, and fortunate for the patient, surgery has been relegated to a secondary position. Now we see less number of patients coming for surgery. Similar thing has happened with peptic ulcer disease, if you think carefully. When we were registered, almost every casualty we had perforated peptic ulcers coming. Now hardly we see any peptic ulcer because with the H2 receptor antagonists advancing, protein pump inhibitors are being introduced, prokinetics, now we don't hardly see patients coming peptic ulcer perforation. So this is what medicine has, medical interventions have changed the epidemiology of certain diseases. So I think as clinicians, we have to understand the dynamics of diseases, how they have changed with medical therapy. Even surgery has changed to certain things. So it has been relegated to a second. So surgery in prostatic disease, prostatic enlargement, and peptic ulcer disease has been relegated to a secondary position because of medical therapy. Other physicians can rejoice, but it is not a debate as such. As clinicians, we should be happy that patients get symptom relief with minimum interventions. Surgery is there always for a problematic situation. But as clinicians, be it surgeons or physicians, we have to be happy that medical therapy is helping patients in a big way. It is because of the scientific foundation that we have. But there is a place for surgery still in benign prostatic enlargement or benign prostatic hyperplasia. If a patient has acute recurrent attacks of acute retention, the patient has chronic retention of urine, recurrent urinary tract infections due to obstruction, prostatic hemorrhage, if the patient has obstructive uropathy secondary to renal function, secondary to prostatic obstruction, like in chronic high pressure chronic retentions, calculi due to the blood outflow obstruction, and finally, if the patient is unsatisfied with medication, with this traditional medication, we have to think about surgery. Now, in modern urology, this is the place for surgery. If a patient with benign prostatic enlargement, still all urologists around the country have loads of work with prostate surgeries, but now it's a diminished role that we are playing. This is rather old statistics, but which I like to quote. In 1989, if you look at TURPs, number of TURPs per 100, this later statistics I could get on, but USA, we see 15 coming down to 5.8, and it should be even less now. Germany, in France, it has come down from 14 TURPs into 4,000 to 8.9. So this shows how the disease epidemiology can change, interventions can change. So BPH is now moving from the scope of surgical urology. So Dr. or Mr. Arbo's role, his role here has now diminished with medical therapy. So equation is changing towards medical therapy when it comes to prostatic enlargement. But of course, we have to take well-reasoned decisions, and we have to understand where surgery is really required. So this is not a debate between physicians and surgeons, but this is a debate to decide on what is best for the patient. Then I would like to briefly touch on medication to help hold urine and prevent leakage. Of course, there are different types of leakages. We see stress incontinence, urge incontinence, and also overflow. Actually, overflow incontinence is also part of blood outflow obstruction, actually, but I'll not delve on those technicalities. So urinary incontinence, we all know what incontinence is, but definitionally, the International Continence Society, the ICS, defines it as a condition where there's involuntary loss of urine, where it is a social or hygienic problem, and it is objectively demonstrable. So it's involuntary loss of urine. It's a social and hygienic problem, and it's objectively demonstrable. So we have to demonstrate as a sign as well. As I told you, there are different types of incontinence. Stress is in male in gynecologic practice. Urge incontinence, everywhere we see different types of situations. Overflow is retention with overflow with blood outflow obstruction. Chronic retention states, we see overflow incontinence. Once again, this is a very important principle that we have to have in mind when treating people with continence. I'm sure with our intercollegiate cooperation, I'm sure if all of us get together and think, this will be very nice. It's a progressive management, starting with conservative methods and then working towards surgery and then complex surgery. So it's a progressive management. We have to analyze the patient and think about methods available and go from simple conservative methods to complex surgery. That's the first principle. Secondly, we have to be mindful of general support of patients. Well, it's up to you to reflect and see how this works in our own setup. I'm not going to be critical. Self-reflection would help us. Aspects of living, quality of life of issues, pads, special pads, catheters, appliances. How much are these patients supported? And there should be, thirdly, cooperation with urologists, gynecologists, nurses, community level support. Once again, it's time for reflection for us when we think about principles of restoring continence. Now, urge incontinence or the overactive bladder syndrome, there are two conditions. One thing is idiopathic detrusor overactivity, where we don't know what the cause is, but they have overactive bladders and they leak urine, they have urgency. Neurogenic detrusor overactivity, this was called formerly detrusor hyperplasia. There was numerous neurological conditions, corticoid tumors, and so on and so forth. A lot of problems, they have a neurologic basis. So definition now we use idiopathic detrusor overactivity and neurogenic detrusor overactivity since 2002. Since words detrusor instability is no longer used technically, and hyperreflexia is not used. So this is what we see people rushing to the toilet. I'm sure some of us would have experienced some time rushing to the washroom to pass urine. Probably some people would have had experience like this. I mean, nothing to laugh at all. So I think this is real life. Once again, if you go for at another level, in a Venn diagram, we see there's overactive bladders. There are one thing is overactive bladders which are dry. Within that, we have overactive bladders which are wet. And intersecting with that, we have the stress urinary incontinence. And then we have isolated nocturia. Nocturia is also now considered a separate disease entity. Nocturia is no longer a symptom. It is a disease and it's another field. So these two types of patients, these textured areas show with incontinent patients. And these people are not continent. They are not incontinent. So these Venn diagrams have been unified to a complex Venn diagram, but I'll not confuse you all tonight, this weekend. But overactive bladder also can be characterized separately through urodynamics. Urodynamics are pressure tests we do to ascertain the bladder and rectal pressure volumes, and then we diagnose. Behavioral therapy, of course, if you have a frequency volume chart or you're in avoiding diary, we can correct it. But in Sri Lankan context, it works in certain situations. The patient has some awareness of the disease, alteration of drinking patterns, and lifestyle modifications. Sorry about this. So behavioral therapy, lifestyle modifications also would help. But the drug class which is being used widely now are the drugs which inhibit the muscarinic receptors in the bladder. The acetylcholine receptor with the muscarinic and nicotinics, if you remember, right? So there are different M1 to M5. There are 5 different classes of muscarinic receptors. And M2 and M3 types are predominant in the bladder. And through studies, it has been shown that we can block these drugs, the receptors, by using different drugs. We have oxybutynin, tolterodine, solifenacin, derifenacin, festoridine, propivarin, trospium. At the moment, we see these drugs will being broadly used in Sri Lanka. But of course, each drug has different side effect profiles. So different drugs have different actions on cognitive function. So we have to be very careful when we use them in the elderly. But of course, they give excellent quality of outcome. But of course, there's cross-reactivity. They also act on salivary glands, and you can have a serostomia, and these patients can have problems. But antimuscarinics, oxybutynin, tolterodine, solifenacin, which are used commonly, can give excellent symptom relief in these patients. So overactive bladders are diagnosed ideally by urodynamic investigations with bladder pressure flow measurements. But unfortunately, we don't have recourse to urodynamics that widely in our country. So symptomatically, we had to treat this patient. But you have to remember, there are sensitive bladders, people who have sensory bladders who would not respond to these drugs. Then other drug which has come to the forefront, but not being widely used so much, is a beta-3 adrenergic agonist, mirabegron. There's a lot of industrial promotion of this drug. It relaxes smooth muscle of a bladder through stimulation of beta-3 adrenergic receptor. So once again, it is clear how functional characterization has helped us to understand disease. Mirabegron is being used in the West, and a lot of combination studies have gone on, but still it's not broadly available, licensed in Sri Lanka. But it has sort of a significant renal and hepatic impairment profile. Then this, the wand drug, the botulinum toxin injection into the bladder, but they have to be repeated every 6 months or 1 year. Intravesical injections, which can be done through flexible cystoscopy as well, but they have to be repeated, and higher doses are required for people with neuropathic bladders. Botulinum toxin also can be used in overactive bladders. And there are continuing research going on potassium channel openers. And also there are studies going on and instillation agents that can be used. They act locally by in the third row, where these drugs are instilled into the bladder, and there's a local action, especially capsaicin. We know the common capsaicin that is being we talk about. Capsaicin and resiniferatoxin are being studied. And of course, they are not in wide clinical use. Of course, botulinum toxin is being used, especially in neuropathic bladders. So when these conservative measures have failed, either the drugs, especially the antimuscarinics, and also if there's failure of botulinum toxin and other behavioral therapies, there's surgery. Substitution cystoplasties, where we can substitute there are certain we can bring bowel in between the bowel patches, where we can take away the muscles of the part of the bladder, or diversion. those are available. Those are very radical. Then the final, briefly, I will talk about medication to expel stones. But a lot of people tend to abuse these things, and this is a rather exaggeration of the stone. This type of stones will never, ever, ever come with medication, as common sense would dictate. Mainly for these are for small distal uritic characters. Once again, it's very important to realize how we define the size of a stone. We have to think uretase as like a tube. And what is important if you look at the stone is the diameter of the stone. So when we talk about ureteric stone sizes, we are bothered about the diameter, not the length. That's something which is we have to understand very clearly. So these are for small ureteric stones, which are less than 10 millimeters. But then they are in the lower ureter. There's a heavy population of alpha-1A receptors in the lower ureter. And studies have shown that alpha receptor agonists tend to relax the smooth muscles of the lowermost ureter. So tamsulosin, terazosin, doxazosin, tamsulosin is widely used. And even calcium channel blockers have been used. And they promote spontaneous passage of stones, small stones. But the most important thing is that we have to make sure the patient does not have an obstructed system with increased serum creatinine, or the patient does not have any infection. In the presence of obstruction or infection, actually those are urological emergencies which would require decompression through stenting, or if the stenting is not possible, through PCN. So percutaneous nephrostomy. So these use of medication to expel low ureteric stones have to be with a narrow margin. So they have to be very carefully assessed. Some benefit from calcium channel blockers, as I said. Well, urologists don't want to take it to themselves, but it should be ideally managed with good judgment, not just right tamsulosin, tamsulosin, tamsulosin. Let us take X-ray, come again. Let us take X-ray, come again. But it needs meticulous evaluation, patient symptoms, things. So many factors to be considered, as I told you before: obstructive status, renal function status, infection, patient bother, and stone progression. So it is, of course, personalized. Depending on each patient, we have to think. Then came a study, the SUSPEND study in the Lancet. It refuted the MET theory, where it said MET is ineffective. But there are a lot of criticisms of the SUSPEND study. It's SUSPEND means actually spontaneous urinary stone passage enabled by drugs. Spontaneous urinary stone passage enabled by drugs study, SUSPEND. But there are a lot of design flaws and a lot of endpoint consideration defects, which is now critically looked upon by critics of the SUSPEND study. SUSPEND study refuted the value of medical expulsive therapy. Well, if MET fails, endoscopes and scalpels will come to the forefront. So we can't say sine scalpello, like in collegiatum sanctia. If MET fails, we have various options: ureteroscopy, URS, and we have electrohydraulic ultrasound. Then we have the extracorporeal shock wave lithotripsy for some renal stones and the ureteric stones, but there we have to appreciate the renal anatomy. Retrograde intrarenal surgery, often this has been used. This is flexible ureteroscopy, where you can enter specific calyceal systems and use laser. Percutaneous nephrolithotomy is another minimally invasive method where PCNL, and now of course we have supine method, and we have mini PCNLs, and patient can go home the following day. Open surgery, still we do practice, but in the modern context, only 5% of urinary tract stones are subjected to open surgery. Now, this picture, actually, this is one historical picture which reflects very badly on surgery when physicians were ashamed to sort of consider surgeons as part of their fraternity. So, and there were these barbers and guys, ordinary guys like us had to practice surgery, where physicians distance themselves from us, and that's why this big Doctor and Mr. Division has come in the UK and the West. So stern surgeons in action, how cruel this is. It shows how a person is being held by many people, 2 or 3 people, and then we see the patient being held like this and cutting into the stone onto the zone through the perineum. And this is what was happening in the 16th, 17th century. And this gave the origin to the term, the lithotomy position. What we use in the theaters, we say lithotomy. This is the lithotomy position. And this was so very cruel. But in that time, during that time, it was not cruel because they were treating stone disease. This is the origin of the Hippocratic oath also, cutting to the stone. We shall not cut to the stone. But now I think we'll have to amend the Hippocratic oath because we are not, these cruel things don't happen. Now cutting to stone is so very gentle. This is modern urology, we say. Extracorporeal shock lithotripsy, how comfortable the person is. We're so very nicely lying down. We have the fluoroscope and localization on 2 planes. We have ultrasound localization. So very comfortable. Listen to some pipe music and getting his stone crushed. He comes the same one morning and goes the same afternoon or the same morning. And this is the difference of modern old urology and modern urology. So we have come a long way from savage forms of surgery. Understanding of urinary tract function together with the physiological and molecular bases has enabled to develop new medications. Medication has obviated the need for surgery in some urological problems. However, surgical problems options continue to be part of the armamentarium available to the urologists. Medical therapy and surgery should be carefully tailored to meet the needs of the patient and his or her condition. This is the requirement for personalized medicine, where we have to treat the patient with the problem, then the problem. Although medical expulsive therapy seems to be attractive, it should not be taken lightly. Well, ideally planned by a urological surgeon. Further advances in urology's research is bound to bring about management changes in the future. Not only urology research, I think medical research, surgical research. This is the truth for the mankind. It will bring about management changes in the future. This will further distance the patient away from the wrath of scalpels and endoscopes. So probably we can manipulate disease, molecular manipulation, genetic manipulation, understanding molecular basis of disease. So medical urology is in a continuous state of flux. I wish to once again thank Arosha and the College of Physicians for affording this opportunity. And we as the College of Surgeons are so very delighted about this invitation. And we look forward to working together rather than having debates for the betterment of patient care, betterment of patient outcomes, and every nook and corner of this country. People have access to excellent medical and surgical care. And thank you very much and have a pleasant weekend. Thank you.
Thank you very much, sir, for that eloquent presentation. We now have a few questions from the audience. Dr. Indika Boteju has asked, about, is there a place for pelvic floor muscle exercises after childbirth to prevent female urinary incontinence in menopause? If so, are there any recommendations? So pelvic floor muscle exercises after childbirth to prevent female urinary incontinence in menopause.
Well, that's a very complex question with urogynecology. Pelvic floor exercises, especially Kegel exercises, are useful in preventing, strengthening the pelvic musculature. But it's once again, SUI can be multifactorial. So it may play a role, but I'm not very sure about the evidence that would prevent menopausal SUI. Honestly, I can't answer that question to that length.
Right. There's another question. In your practice, have you seen males with metabolic syndrome with diabetes and hyperlipidemia showing a faster developing BPH? Or are they more frequently candidates to BPH surgery?
Patients with BPH, especially diabetes or diabetes, especially some people have diabetic cystopathy, which is also sort of a part of their neuropathy, and they have overactive bladder symptoms supervening on the prostatic enlargement. Once again, we have to appreciate that this is the aging bladder as well, so there are bladder changes as well. So, well, it cannot be said that it is more common in diabetics. I would say it is almost the same. But the manifestations with uncontrolled diabetes would certainly overlap with the recognized BPH symptomatology.
Right. Now, there's another question. What standard investigation should have been done when a patient sees the urologist?
Well, once again, we have doctor shopping here in Sri Lanka. Ideally, they should be seen by a GP. But of course, the symptoms have to be analyzed really well. What type of voiding, storage symptoms they have, and what type of class of symptoms are overlapping. Then at least a urine analysis, basic urine analysis is important. Yeah, urine culture with ABSD. And also we need to assess their serum creatinine, basically at least. And imaging wise, at least ultrasound scan of the abdomen. It's not a pure abdomen, but it's an ultrasound scan of the abdomen with pre-void and post-void volumes. That is required. Just a plain scan will not help us. And also the prostatic size. PSA, once again, it's a big debate. Are we going to do PSA in all patients or not? There are affordability factors, but of course, most of the government hospitals have PSA now. Once again, PSA is subject to the conditions that I elaborated. Those investigations would be really useful to a urologist.
Right. Another question is patients with sterile pyuria, let's say while investigating for other medical causes like renal TB, should we refer to the urologist, and when should we refer?
Oh, that's a difficult question. Sterile pyuria, of course, raises the specter of tuberculosis. So, of course, the urologist would be part of the investigative process. Of course, sometimes even the PCR tests are not very useful when it comes to investigation of sterile pyuria. But of course, there's a place for cystoscopy in these patients. So, urologists, there'll be no final. Urologist is not the final arbiter, but urologist would be part of the diagnostic team.
Dr. Arosha.
Yes, I hope I'm unmuted, right? Satish, thank you very much for an excellent talk, a very erudite one. I have one or two questions. One is, you didn't mention prazosin at all among the list of medicines that you spoke about. Is there any reason to avoid prazosin? Is it no longer recommended?
Prazosin is more history now. It's historical. Prazosin has its own side effect profile with prominent vasodilatory effects. But still, due to affordability factors, patients go for prazosin. But if you look at the literature, current literature, there's no advocacy for prazosin. But still, historically, prazosin is being used. Maybe 15 years ago, 20 years ago, I was using prazosin a lot. But now, with better treatment outcomes, the swing has been towards tamsulosin and silodosin. Prazosin can be used. But on the other hand, terazosin is still being used. And up to, but prazosin is not widely used, Sarveshana.
Right, because for a physician, prazosin is quite a good friend because it can be used for dual purposes for us when the patient has hypertension as well. So when we need to treat hypertension and LUTs, we kind of, at least I tend to use prazosin. I was just wondering whether that is...
You are opening a pathway for a good study actually, where we can cooperate. We can do Euroflow studies in our department, and we have any department in the country, and we can see how with the symptom scoring system, how it helps. I'm sure prazosin is recognized, but we can do how these two, the therapy would help the patient. Yes, excellent. Actually.
The second question, Satish, is now for LUTs. Now there are the 5-alpha reductase inhibitors as well as the alpha blockers. Now you did mention one study which had used those in combination and shown good outcomes. I'm just wondering whether we should actually, in all patients, whether we should start both at the outset.
I am most of us actually currently we
try
use
one
both.
and go. What are your thoughts on that?
I tend to use both drugs together actually.
Right.
And anecdotally, of course, I don't have definitive evidence, but anecdotally, I could say that they have better performance actually. But the evidence continually show that combination therapy works really well. Yeah.
Right. Do you combine that with tadalafil as well? I mean, I didn't know, to be honest with you, it's probably my ignorance, but I did not know about the place for tadalafil in the treatment of LUTs. Do you combine that also with that?
Tadalafil, there are no studies which show that combination of 5 ARIs, 5 alpha blockers and phosphodiesterase inhibitors like tadalafil. But tadalafil alone also can be used because it has shown that tadalafil has good effects. I'm sure a combination will be no hindrance for good outcomes. But that will both address, as you say, in a nuanced fashion, the treatment of bladder obstruction and erectile dysfunction. I mean, there are lots of studies, yeah, and there are Cochrane reviews as well. Which look at these different aspects.
Just one final question. That is, now when we do start somebody on tolterodine for urge incontinence, should that be continued long term for years and years, or do we treat some time and see?
One thing we have to be very careful when sometimes you can use with bladder outflow obstruction also, but you have to make sure that they don't have a high post-void residual volume, more than 150 ml. If they have a high volume, they would tend to go into retention of urine. Long term, yes, you can use, but of course, we have to be very careful about cognitive disorders that could occur, especially in the elderly. One can use tolterodine in a sort of a long action extended release formulation on once daily dose. Yeah, you can use it long term with adequate monitoring.
Is Urimax's only indication in a woman that of MET, medical expansion therapy? Is that the only reason why not Urimax, I'm sorry, tamsulosin would be used in a woman?
Once again, for certain bladder outflow obstructions in women, the tamsulosin has been used. Once again, this is anecdotal, but there's no evidence to show that bladder outflow obstruction in women is addressed by tamsulosin, but because the pathology is totally different in women, there could be structural problems, strictures, bladder neck sclerosis. So the smooth muscle architecture is so very different in the woman. So it's quite different. If you look at the prostate, it's full of smooth muscle and glandular structures. So once again, it's a physiologic issue which we have to consider.
Right, Satish. So before I hand over to Himanta to conclude the session, I just want to thank you once more and say that, you know, we started, our theme is in Latin. And then of course, when you sent the topic to me saying urology without the scalpel, I thought we'll add some French and got in urology sans scalpel. And then of course, in the council meeting, there was quite a lot of humor saying that we were hoping that the lecture would not be Greek to the listeners. And I assured the council members, knowing Satish, having listened to him and how clear and beautiful his explanations are, I said this will be one of the most easily understood lectures, however complex the subject matter is. And you've proven my word. Thank you for such a beautifully clear, lucid lecture. It is very much English and not Greek at all. Thank you, Satish. And Himanta, you may take over.
Can I add one word?
Yes.
Arosha hook penetrate in a scalpel. We come the surgeons without the scalpel. And it's an immense pleasure. And I bring warmest greetings from all surgeons of Sri Lanka and the College of Surgeons. And we are committed to working together with all the colleges for excellent care.
Okay, then. Before we wrap up today's proceedings, I would like to remind our dear audience that the second webinar of Collegia Newton Science will be held in the month of March. I would like to thank Dr. Satish Gunasinghe, the President of College of Surgeons, Dr. Arosha Disanak, the President of CCP, Dr. Dinesha, Dr. Sudarshan, our dynamic secretaries of CCP, for all the assistance provided, and especially Dr. Chandimani, the AV team of CCP, and of course, the attendees themselves, who braved the power interruptions to join us. Wish you all a pleasant evening. Good night.